So for our academic session today, Dr. Andrew Merritt at PGY4 is going to lead us in a discussion of ankle arthritis treatment, fusion versus replacement. Dr. Merritt?
Thank you very much. Like Dr. Sangeorzan has said, today we're going to be talking about ankle arthritis. This right here is ankle arthritis. These two x-rays belong to a gentleman named Mr. Williams. It's not actually his name because of HIPAA reasons, but we'll call him by that. Mr. Williams is a very pleasant 86-year-old gentleman from Eastern Washington that came to see Dr. Hansen about 7 years ago. He was pushed into the clinic in a wheelchair by his wife. He was otherwise healthy. He had no heart disease, no lung problems, didn't have any cancer. He was a healthy 86-year-old gentleman. He just had two really bad ankles. He talked at this clinic visit about how him and his wife used to always enjoy strolls after dinner for his exercise, and now anytime he leaves the house, it's in a wheelchair. He required braces every time, even walking around within his house to get up to the bathroom at night or anything. He required braces because he was in so much pain from his ankles. I was fortunate enough to see him 7 years later. At this time, he was 7 years out from his right total ankle arthroplasty and 6 years out from his left total ankle arthroplasty. I was pretty inspired, so I took this video of him walking straight down the hallway with pretty minimal limp. He's, keep in mind, 93 years old at this point, 2 ankle replacements, otherwise really healthy individual. So we're going to be talking today about arthritis, ankle arthritis, but it's clear that to a lot of people it's much more a bigger issue than just a couple of x-rays that look pretty bad. But how many people like Mr. Williams are there out there? We need to talk about the severity and the incidence of this to put it into perspective. So it's actually not very common. Only about 1% of the population has ankle arthritis that's symptomatic. This is much less common. In fact, it's 9 times less common than knee arthritis. And proportionally, it's treated even less than that. Only about 16,000 ankle fusions and ankle replacements are done every year. And for this, that's 24 times less common than total knee replacement. That's the treatment, general treatment for knee arthritis. So the truth is it's not actually that common. But many people have dedicated their entire career to this problem, including the 3 people that are talking with us today. So clearly it's an important problem, but why have they spent so much time dedicated towards treating this? Well, the truth is this is a complicated problem. And turning this into this, which is Mr. Williams' x-rays at his current visit, is an even more complicated problem, much less to have him walk straight down your hall with a barely noticeable limp 7 years later. So to talk about ankle arthritis, we need to start at the beginning and talk about the ankle joint. It is nice to make analogies to the knee and the hip because that's where we most commonly see arthritis. But in fact, it's actually a very different joint. The surface area at physiologic loads of the ankle joint is only about the size of your thumbprint, about 3.5 square centimeters. That's compared to about 11 square centimeters in the hip and the knee. So it's a much smaller joint. The mechanics are also different. It's much more of a rolling joint. There's not much rotation. There's not much translation in the ankle joint. Also, the surfaces of the tibia and the talus don't always line up perfectly. They contact different places through your different phases of gait. And as we all know, the talus is wider anteriorly than it is posteriorly. And this is thought to have a beneficial effect on the cartilage of the talus because it has different areas that are contacting during range of motion. It's thought that this increases lubrication and nutrition of the cartilage. The cartilage itself is also very different. This is a cadaver slide here, and you can see that the cartilage is actually quite thin. It only averages about 1 millimeter to 1.7 millimeters in thickness. That's compared to over 5 millimeters in the knee joint. It's much different cartilage as well. It's stiffer cartilage, it's more resistant to denting in mechanical studies, and also it degrades less over time with age. So while the analogy is similar to the hips and knees, the bottom line is why an ankle like this turns into an ankle like this is very different. It's not like a hip or a knee. We're going to talk about how this process happens, how you get nice cartilage to turning into a cartilage like this. And there's multiple studies that have talked about this, but unfortunately, the definition of ankle arthritis in the studies is not always perfect. It's not always the same. So we need to come to a consensus first. Many people, including Gons from Switzerland, have studied that the correlation between x-rays and clinical symptoms is not as closely related as it is in the hip and the knee. So generally, for most of the papers that I'll be talking about today, they'll use a combination of severity on radiographs, the same that we use as a knee, joint space narrowing, sclerosis, osteophytes, and clinical symptoms of severe pain in the ankle. And that combination is what most studies have related to being called severe end-stage arthritis. Dr. Saltzman looked at 639 patients from Iowa to look at the etiology of ankle arthritis. Now, this is a very busy slide. I would just like you to focus on two areas here. First, primary ankle arthritis. Unlike the hip, which is about 65% of the time, it's primary osteoarthritis of the hip, or the knee, which is 82% of the time, primary osteoarthritis of the ankle is actually quite rare. It's only about 7% of the time that a non-traumatic, no other reason for ankle arthritis leads to end-stage arthritis. And most of those 7.2% had some type of deformity, hindfoot deformity or tibial deformity that was likely the cause. The vast majority, as you see here, 70%, is due to post-traumatic causes. So Dr. Saltzman continued to look into the post-traumatic causes and came up with some interesting data. Recurrent ankle instability, so people that just have lots of sprains through their life, it's about 15% of the population that develop post-traumatic arthritis. Also, about 14% were just single sprains, people that had one sprain in their life, but they had continued pain after that. It's likely due to osteochondral defect or some sort of cartilage lesion at the time, which led them to have the continued pain. But these poor individuals only had one sprain in their life, ended up with end-stage ankle arthritis. The most common, 37%, was just rotational ankle fractures, the kind that we see in the emergency department every day. A study published in Core out of Switzerland looked into this as well. They found that their numbers correlated quite well to Dr. Saltzman's study, and they found that between ankle sprains and common ankle fractures represented 55% of the people that they noted in their study that had end-stage arthritis. Their follow-up study that was published in 2009 in the Journal of Orthopedic Trauma looked at the type of ankle fracture and the type of fracture and how it related to the development of arthritis of the ankle. What they found is, like the other studies, just rotational ankle injuries were the biggest cause. Of these, type B fractures were the most common. And again, these are the kind that we see every day. These are bimalleolar fractures in the emergency department. So we treat these patients every day. But as you can see from this slide in that same Journal of Orthopedic Trauma study, it doesn't happen for quite some time. There's a latency period of 20, 30, even 40 years. So the ankle that you treated young as a resident might become a patient of yours many decades later when they have ankle arthritis. But we know that only some of the ankles that get these rotational ankle injuries develop arthritis. So which ones do and which ones don't? And that's an interesting subject, and our role in it is mainly the quality of the fracture reduction. It's been known that any step-off, any malunion can increase the contact forces in the ankle, so that's the main component that we have control over. But recent studies have shown that it's probably the cartilage damage that happened at the time of the fracture that is a significant role in this. There was a JBJS study recently in February of this year from Switzerland that at the time of open reduction internal fixation of the ankle fractures, they did arthroscopy and evaluated the cartilage damage, and 55% of the patients that they evaluated had a significant cartilage lesion at the time of that relatively simple ankle fracture. And they noted the increase in severity of the cartilage damage was related to the development of osteoarthritis in their follow-up study. We also know that the severity and the fracture type, it clearly makes sense, would lead to different rates of osteoarthritis. And And one thing I would like to touch on just real briefly, because it's becoming more explored in the literature, is posterior malleolar fractures. What we do know about these is that they increase the development of ankle arthritis. So it's been found in previous long-term follow-up studies that about 33% of the time, if you have a posterior malleolar fracture, you will go on to develop end-stage ankle arthritis if followed for long enough. This is compared to about 4 to 10% for ankle fractures that do not involve the posterior malleolus. People talk about you need to fix these when it involves 25 or 33% of the plafond, but these numbers are actually pulled from old studies that are mainly anecdotal in nature, and it's not firm research that's behind those numbers. There's also been a recent study, March of last year, in Journal of Orthopedic Trauma that talked about getting CT scans on all of the trimalleolar fractures because radiographs alone were insufficient for evaluation. And here's one example of that, where you have a flipped osteochondral fragment that would block the reduction if tried to do percutaneously and if you did not know it was there. And they found that about 55% of their patients had some type of comminution or a lesion that likely would have blocked an anatomic reduction. And we know that the anatomic reduction is important. As we talked about before, even a 1 millimeter step-off has been shown in studies to increase contact forces about 35% in the ankle. In addition, Dr. Gardner, who's a previous trauma fellow while he was still at HSS, did a study that looked at syndesmotic stiffness as related to fixation of the posterior malleolus and found that it stabilizes the syndesmosis significantly. But no matter how we treat these, some amount are going to develop ankle arthritis, and that's the main subject of our talk today, is how to fix these. There's obviously conservative management. That's not what we're chatting about today, but there's clearly bracing and there's activity modification, rocker bottom shoes, injections that you can do for conservative management prior to surgery. But the mainstay that we're going to be talking about is surgical management. Just like a high tibial osteotomy for the knee, supramalleolar osteotomy can be done for certain types of ankle arthritis, such as in this 38-year-old male who recently underwent a supramalleolar osteotomy to correct his varus malalignment at the ankle. This is trying to buy some time because 38-year-olds, as we know, don't have great options for end-stage arthritis. So if we can get him more years off of this ankle, it would be much better for him. One group in particular out of the Netherlands has talked about articular distraction. What that involves for us that is not familiar with it is putting a ringed external fixator on for about 3 months after cleaning up the ankle joint with arthroscopy. And they feel that this creates a better environment for healing of the cartilage and can delay the need for ankle fusion or ankle replacement. There's also allograft arthroplasty, and I took this case from a recent Journal of the American Academy of Orthopaedic Surgeons who talked about its use in young patients with severe ankle arthritis, that a full allograft talus and tibial component can be used. And while this is still being developed and there's some complications and risks in using it, it shows some promise for the future. With this being said, the mainstay workhorse for end-stage ankle arthritis is replacing it, or ankle arthroplasty, and arthrodesis, or ankle fusion. And we have 3 great speakers that are going to come talk about their careers in managing ankle arthritis and their development of surgical techniques and indications for arthroplasty versus arthrodesis. The first person I would like to bring up is Dr. Rob Veith. He's a clinical professor and works down in Renton, but is a close friend of ours here. He was a previous resident here in our program and then was on faculty here for 3 years. Is that right? For 3 years, having clinics here at University of Washington, at Harborview, and at Children's Hospital. And he's going to talk today about ankle fusion and his indications and treatment plans for that. So, Dr. Veith.
Great. Thank you, Andrew. Great. It's great to be here, back on the campus. Wanted to thank Dr. Chapman and the Orthopedic Department for inviting me. It actually has been years since I've been on the campus, and I noticed my brother, who's chairman of psychiatry, is here, and I'm glad he finally got that restraining order lifted. But whether I'm down at Valley Medical Center in Renton or treating neglected club feet in the mountains of northwest Vietnam, Fusions of about the foot and ankle can really solve some very challenging problems. And this is a young man I treated a few years ago in Vietnam. And I had a Lambernuti type triple arthrodesis. I saw him just a few weeks ago, and he's doing very well. Took this young man who really did not have a future at all, and now he's got a great job and is about to get married. And so fusions can solve some very difficult problems for us. The primary indication for an ankle fusion is disabling arthritis. These patients have pain, and they've failed conservative treatment, and we're faced with doing a procedure that's going to get rid of their pain, correct their deformity, and if they have some instability, address that as well. So the goal of an ankle fusion is really to provide comfort, but to also achieve a plantar-grade foot when doing so. Ankle fusions tend to do very well because of neighboring joints. So we really have to rely on adjacent joints to maintain mobility. And these joints over time do tend to stretch out a little bit. That ends up improving our gait. But it may come back to cause some troubles, this increased mobility, and may end up ultimately leading to some arthritis of these joints. One thing I really like about an ankle fusion is it's very durable. Many of these patients are workers, and they're on their feet, and want to do sports, want to hike, want to ski. And I feel much more confident with fused ankles doing activities that involve loading. Some of the conditions that may lead to the need for an arthrodesis include osteoarthritis. This patient probably has an element of post-traumatic ankle sprains in the past. But you can see on the x-ray there's loss of joint space. This gentleman's in his 50s, and you can see how the talus gets extruded forward. And an arthrodesis is just a great way to go. This gentleman ended up with bilateral ankle fusions. He's been able to travel the world, sent me a postcard from the Dalmatian coast, and he's been very happy with his resolution of pain. Post-operatively, again, these are very durable. We get the talus back a little bit, improves the gait, and patients like this can do very well for quite a few years. Post-traumatic arthritis sometimes is a common indication for an ankle fusion. These patients can have varying degrees of deformity, can have soft tissue issues we have to deal with, scarring, may affect our incisions. But here's a patient with post-traumatic arthritis, and obviously an open procedure is necessary to clean this joint out and correct deformity, get rid of all this hypertrophic bony stuff. And here he is with our typical open arthrodesis with screw fixation. Screws don't penetrate the subtalar joint. This was actually an outpatient arthrodesis at his request, and he did very well. Sometimes you get a patient with septic arthritis, kind of unusual, but this patient had a MRSA infection, had 3 debridements, was just not doing well at all, and ultimately was faced with either an amputation or an attempt to salvage. And this is one time where an external fixation type arthrodesis can be a great save. And this patient had an old-time Calandruccio clamp put on, very simple external fixation device, very well tolerated, skin cleaned up very well, and he went on to a very satisfactory outcome. I'm not sure he ever fully healed, but he's got his foot and is doing very well. So a good way to treat an infected ankle is external fixation. And I tell my patients, hey, one of the treatments for an infected ankle, if you ever got an infection after surgery, which is very rare, the fusion is the answer for an infected ankle. Sometimes we'll get patients who have both ankle and subtalar arthritis, and if you're not sure as to the severity of the neighboring hindfoot joints, a pre-op CT scan can be very useful. I think you can see on the AP view that there's quite a big cyst in this talus, and the CAT scan can really show what's going on, and it's very important. Sometimes we'll have to do some differential injections as well to determine which joints are really causing troubles. In general, I'd prefer not to fuse an ankle and a subtalar joint simultaneously because I think it increases the risk of one of those joints not healing, but in this case, no choice but to do an arthrodesis nail, and he went on and did very well. Sometimes you get some weird deformities. This patient was in Las Vegas and lost the end of his tibia on the highway. A doctor in Las Vegas did an Lizaroff procedure and linked in his tibia, but he still has this perfect foot that's not attached to his tibia. And I saw him a number of years ago and applied one of these Calandruccio clamps. And he went swimming every day with it on and ended up with just an outstanding result. He's back at Boeing working. I probably would have used a nail now, but he has preservation of his subtalar joints, and this has been a good answer. A fusion can be a good answer for some very difficult problems. In regards to patient selection, we always want to have a patient who's failed conservative treatment, and we'll do some pretty exhaustive conservative treatment measures such as AFOs and injections, so to speak. And ultimately, if the patient fails conservative treatment, has disabling arthritis, and ankle arthrodesis is the way to go. I try to make sure I'm not dealing with a smoker because that's just going to increase my risk of getting a healing problem. So try to avoid that. Make sure the patient has good circulation. Document if there's some atherosclerotic conditions that you have a Doppler study showing they have good circulation. Our diabetic patients with neuropathy pose a special problem, and this patient was walking on her recently fixed trimalleolar fracture elsewhere and was not painful at all. And doing a standard fusion with screws is probably going to fall apart. And this lady ultimately ended up with a retrograde nail, orthodesis nail, and has done very well up to this date. So in regards to surgical technique, these can be done either arthroscopically or open. And we'll talk a little bit about arthroscopic, but I noticed Dr. Kringle's here, and that's his son with the camera in the background. He was with us in Vietnam a few weeks ago. But in terms of arthroscopic procedures, I actually have zero experience with arthroscopic, except for this patient who came to me with a non-union. But the key on arthroscopic fusions, if you're ever going to do one, is they really have to have very minimal deformity. You can't be correcting any malalignments or removing hypertrophic stuff. So arthroscopic, this patient actually ended up going ahead with an open procedure and went ahead and fused. Most of our procedures are going to be done open, and whether we're doing open or arthroscopically, we'd like to get the patient in a few degrees of external rotation, 0 to 5 degrees of dorsiflexion, really avoid plantar flexion if at all possible, and a few degrees of valgus. And I always try to get the talus displaced posteriorly a little bit. And sometimes I'll do a percutaneous TAL to get it up. I'm not sure a TAL, and I'm not sure you gain a lot with an open gastroc slide versus a TAL in the ankle fusion setting. But I want to get that foot up in the neutral position. In terms of technique, make sure the knee is exposed, and make sure I like to have the foot perpendicular to the floor. That helps me knowing where I'm starting. I want to make sure the C-arm can visualize things very well. Use a transfibular approach, and post-operatively, we need to keep these patients non-weight bearing. It's one of the negatives of ankle fusions. You got to keep them non-weight bearing for quite a while. These new rollabout machines actually help quite a bit in that regard. And even though it's a big open procedure, again, there's concerns about stripping soft tissue. These exposures are excellent, and usually the soft tissues do very well. And post-operative infections after an ankle arthrodesis are very rare. Results, if you look at the literature, are generally very favorable. Most patients would do the procedure again if they got a chance. And patients are always surprised how much mobility they have after an ankle fusion. They're anticipating they're going to have a very stiff L-shaped foot. But with good subtalar and hindfoot joints, these patients actually move quite a bit. You see them walking, they look look essentially normal. Rocker bottom shoes, which are now very easy to get, the Skechers, easy to get a rocker bottom shoe, and those can be helpful as well for the gait. The primary risk of ankle fusions, it's not infections and amputations, it's non-union. So the literature can suggest up to 40% in some series. I usually tell my patients that the risk of non-union is somewhere in the 5 to 10% range. Literature will say up to 20%. But I kind of get them scared that, we've got to really be non-weight bearing in this setting. And definitely do yourself a favor and make sure your patient's not a smoker. The risk of non-union with smoking goes up tremendously. Long term, we're more worried about, are these joints going to wear out? And because joints do wear out, if you live long enough, the interest in arthroplasty is really, really kept hold. And patients can do well for 20 years and then start to really take a nosedive if their subtalar joint becomes arthritic. This patient, both talonavicular and subtalar. This patient had a fusion in the early 90s by one of my partners and did well for years and years, but then started developing subtalar pain and did injections, and finally it was just we had to do something. Of course, the patient who's who's having a lot of subtalar arthritis is also stiff. They're stiff and painful, and we can convert them to stiff and painless by doing a subtalar fusion. And the combination of an ankle fusion and a subtalar fusion is actually not bad. These people do well. There's words going out that, oh God, you might as well have an amputation, but this construct of an ankle fusion and a subtalar fusion is fine for most patients. It's when you get the show parts joint involved, you get a pantalar, that things really start, again, taking a nosedive. But a pantalar fusion is still better than an amputation. I think the people who maybe I think would benefit from an ankle replacement are people who already have a subtalar fusion or a triple and who develop ankle arthritis. And that would be a good setting that would seem to make sense if we can get an ankle replacement in that setting. And this patient was a rheumatoid. She'd had infections with other total joints, and it turned out best for her just to go ahead and and get nailed, and she's done very well with that. But that might be a good setting for an arthroplasty. So if I can summarize my thoughts over a 25 plus year span of doing ankle fusions, is that negatives of these is that they take a long time to heal. Patients have to be non-weight bearing. That's about a 20, 30 pound weight gain in most of our patients. So we want to try to start being proactive about how they eat after their surgery. There's definitely a risk of non-union, so avoid smokers if at all possible. And we warn these patients that down the road they may get arthritis and have to get a subtalar fusion. Again, not a deal breaker, but just this could happen down the road. The positives of an ankle fusion is that they're very good on addressing pain. These patients get relief of their pain, and they get a good-looking ankle out of it. Usually the ankle gets trimmed, and because they have hindfoot joints, it's a pretty good situation. Ankle fusion is a pretty good situation. And should they get a complication, it's not some horrible disaster. Still got all your bone stock there, and so the complications are quote manageable. And so it's been a good, very good procedure for me. A number of years ago, I went to the total ankle course back at the Learning Center. I said, I'm finally going to be a total joint surgeon, and I'm going to get all the glamour that goes with that and everything. So I came back after doing my course, and to date, I've done 0 total ankles. So I'm hoping that our next speaker will convince me that I'm missing the boat somewhere. And Dr. Hansen, of course, is my mentor, and spent years with him. And I've told him he's taught me everything about everything I know, but he hasn't taught me everything he knows. So hopefully Dr. Hansen can fill us in as to why total ankles are the way to go. Thank you very much.
Thank you. Well, first of all, I don't like the idea too much of, first of all, arguing with Dr. Veith. Secondly, this debate, whether you do ankle arthroplasty or whether you do ankle arthrodesis, is a little bit of a false one, because we're talking about different patients. And those of you who know me know that I don't classify patients in big groups, but I look at every individual as to what their problem is and how they got their problem, and what needs to be done to that individual. So although and the reason I should say that I picked up arthroplasty, there was one time years ago that I said, we don't need arthroplasty. They came through in the 70s, and they were kind of a disaster. And so I decided at that time we don't need that. But then Dr. Alvine, who was also from this program, has developed his new ankle. And he kept talking to me every year along his 5 or 10 year development time about his new arthroplasty. And then when he finally got it approved, I realized that we probably did need an arthroplasty, because exactly as Rob has said, we figured out all the ways to do the arthrodesis correctly. And I had some that they'd get so much motion that we'd send a medical student in to see them and see how their ankle was, and they'd come back and say, it's fine. And they didn't have any ankle at all, but they were moving so well through their subtalar joint and doing so well in the early years after the fusion that they didn't need anything else. But then I kept doing them, and some of my best ones came back then with significant arthritis in the subtalar joint and the mid-tarsal joint, so we thought we'd better learn to do arthroplasty. The other thing to keep in mind is that when Charnley started out, I happened to visit Charnley in 1970 when he had his course up in Wigan, and he had had 300 straight failures of his total hip. And, but he persisted. The reason he had a failure, of course, he figured out why he had the failure. He was using Teflon, which the wear products did a tremendous amount of reaction in the soft tissues, and so he quit doing that. So, but the fact is that he knew that we needed hips, because fusing a hip, which is something I did in my training here, which you guys have never even thought about because of what Charnley did. But that was a disastrous problem for the patient and for the surgeon. It was a really hard thing to do. And so we needed total hips for sure. And I think that we have a little bit, relatively less for all the reasons that you heard, but we needed an ankle arthroplasty. If we look at each case, different people need different things. In my estimation then, about a third of the patients, total ankle would be best, a third arthrodesis would be best, and about a third you might use either one. There's reasons you could do either one. The other thing is you've noticed that arthrodesis can be difficult. Rob has shown a lot of nice cases. He does them very well. He's an experienced foot and ankle surgeon. He knows how to line them up. All the criteria that he mentioned are just exactly what I believe as well. But everybody doesn't do that. Ankle arthrodesis is not an easy operation, and ankle arthroplasty is a little bit more difficult. The old joint surgeons, when total ankle arthroplasty came out, some of them thought, well, I'll just add ankles to my repertoire. Doing hips and knees, I can certainly do ankles. They quickly figured that's not right, because I don't know how to line up an ankle. Lining up an ankle means lining up the foot, and that can be very difficult. Most ankle arthritis, as you've also heard, is post-traumatic, and trauma is most common in young patients. But many patients present then for treatment of their ankle arthritis at 35 to plus or minus 10 years, even though, again, as Rob said very accurately, it may take, I've seen people up to 50 years after the initial ankle injury when they finally come in for their ankle arthritis. So it takes a while, but they can still be pretty young. And as you know, all ankle arthroplasty is best done in people 60 and over. So sometimes you would do an ankle arthrodesis, but leave all the bone stock so that when we have to go back, we have enough of the structures, the malleoli, the deltoid ligament, and everything is still there, so you can go back and convert it to an arthroplasty when they're 65, which actually can work. Anyway, the marginal group for a joint replacement would be roughly 45 to 60 years of age, and these are fairly common ages in my practice in the marginal group. Like most joint replacement surgery, of course, it's most reliable in older people, but these cases are rare. I don't see, as the patient that was shown at first, people that come in their 80s and they need an arthroplasty. Those are a slam dunk. It's easy to tell if they've got the right stock. That's a great thing to do for them, but they're not the common patients. Pure osteoarthrosis, again, from the studies that Rob showed you, is uncommon. Almost all ankle arthritis has a history of trauma if you include ligament trauma. And I do. I think that it's an injury, whether it's a sprain or whether it's a fracture is not so important. It was traumatic. And that disturbs the ankle mechanics and it damages the joint to the point that it'll go on and get arthrosis. Pure osteoarthrosis, I almost never see. Maybe one case in 100, I can't find some history of trauma when they come in. And clearly, again, all the other approaches like bracing, debridement, osteotomy, muscle balancing, osteochondral grafts, these are all things that are not done as much in other joints because it's easier to progress, just go ahead and do a total ankle. We even have people that I see frequently now that have tibia vera and they're wearing out the medial side of their knee joint, and I would think they should need an osteotomy, but the joint surgeons are saying, don't worry about that, we'll just replace your joint. It's not so easy to do that in the ankle because the ankle replacement is not as good as the knee replacement, so we would rather do the things that line up the joint and restore the basic biomechanics so that they keep going with their own joint, which is always better than either a fusion or an arthroplasty. Now, in spite of all these facts, the things that we can do, patients have to be treated, even though sometimes what you'd like to do is contraindicated. It's contraindicated to do a fusion because it's going to damage other joints in the foot. It's contraindicated to do a total ankle arthroplasty because they're not very reliable and they don't last more than about 10 years before they get polywear and things. But what if you have a 25-year-old with a talus fracture and post-traumatic arthrosis in both the ankle and subtalar joints and they say, I want this leg off? Well then, it's probably worth doing a total ankle arthroplasty. And I've just seen a couple of patients recently that I did total ankles at the age of maybe 25 to 30 because of just this problem, a talar fracture with AVN and damage in both joints. And they're still going very, very nicely at 12 and 15 years. But we've had to do revisions in both of them. But they have normal ankles essentially in terms of function that allow them to do all normal activities. They probably still will wind up with an amputation because eventually they'll fail. But if they get through their initial 25, 30 years of life with a functional ankle rather than an amputation, as good as amputations are, as Rob and I both know, if you really have to have one, it's still better to have a functioning ankle that looks like everybody else's ankle. Now, fortunately, a number of commonly believed principles are indeed myths. There's a myth that salvage of a failed arthroplasty can be done only by complex bone block fusion. That's not true. They can be done with another ankle arthroplasty with special modifications. A fusion cannot be taken down and a total ankle replacement done later. We do that a lot. That's a myth. A total ankle and a simultaneous subtalar joint fusion should not be done at the same sitting. That's a myth. There's a myth that an ankle replacement cannot be done with a history of ankle infection. That's really not true. I agree with Rob that the best way to treat an ankle infection is with a fusion, but we have been able to do a lot of ankle replacements in previously infected ankles, either infected without an arthroplasty or with an arthroplasty that was infected that we then clean up and put a new arthroplasty in, and they do well. Actually, we have not had, I think, any failures doing that. There's a myth that an ankle replacement is precluded in ankles with significant varus or valgus. That's kind of nuts. You just got to fix the varus or valgus, which any really trained foot surgeon should be able to do, and then you've got a straight ankle, and then you can do an ankle arthroplasty. The alleged gold standard or alternative of total ankle is an ankle fusion. Total ankle arthroplasty treatment protocol then is that we like to do primarily ankle arthritis, not involving other joints. It needs to be good overall alignment, or you need to correct to that. It's ideal if they're age 60 or over, if they have no significant osteopenia, which is unusual. In subtalar arthritis, it's the only good answer because if you fuse the ankle when there's already subtalar arthritis, that joint's going to be a problem. Now here's secondary degenerative arthritis from an old ankle sprain in a former athlete, which is common. They have a lot of problems in the ankles as well as the knees, as you know. 64 is good age, lots of osteophytes. They can all be trimmed out and cleaned up, and he gets another joint. And the reason we say not only because of age, but his other joints in the midfoot and the hindfoot are already a little bit compromised, so you wouldn't want to fuse that on top of that. Total ankle treatment protocol then is acceptable in patients 45 and over who are well aligned, have a low impact lifestyle, good bone size to body weight ratio, and no osteopenia, as I've said. If the subtalar joint is good and with further experience in fusion conversion, we now recommend fusion done in a way to facilitate conversion after 10 to 12 years, and then take it down and do a total ankle later. Here's a 50-year-old female veterinarian. She's a little young, but she's already got, again, early findings in the subtalar and mid-tarsal joint. So we would rather not fuse her, even though in an ideal situation, if those joints were good, we would fuse her now and wait for the 10 or 12 years that might fail, and then we go back and do a total ankle with a subtalar fusion. But she went on very well with this. This is the old days, you can see. We put the distractor on. I no longer use that, but you can see the holes in the joints. And later on, she's doing fine. She's a large animal vet somewhere in the Midwest. So the protocol in patients with major malalignment can be very effective in the hands of a surgeon skilled at realignment, as I've said earlier. Ankle replacement may be as good as fusion or better in a patient with arthrosis in the subtalar joint, as we've just shown. In patients that are over 260 pounds, I don't know if you see this, Rob, but they're difficult to fuse. If they've got a long foot and they got a great big body, as soon as you turn them loose with that fusion, they'll tend to break it down. So I tend to go, in the old NFL and NBA players, I'll tend to go to a total ankle rather than a fusion. In revision cases with loss of the talus, secondary to loose components, or previously or expected coincident subtalar fusion, if they have significant osteopenia or cases with primary loss of subtalar joint, a custom stem talar component can be preferable. You saw one of those in the older man. In patients with total ankle failure, where the reaction to failure often is talar loosening, that was a big defect in the device we had for a while. The talar body did not bond well, and then it was too small, and it tended to migrate down in the bone, and we had lots of problems. Most of those have been solved now. It's interesting it took so long to solve it because the surgeons working with the company knew immediately that needed to be changed, and because of their problems with the FDA and various things, they didn't get it changed for about 10 years. And finally, after that, then the rate of success got much better. In failure due to component loosening or infection but without bony overgrowth and stiffness, the treatment was by revision arthroplasty. In summary, although there is an overlap, in general, indications for fusion and for total ankle replacement are different, which means the idea is that we should do a long-term randomized multi-center prospective study to see if a total ankle replacement has a legitimate place in our armamentarium for ankle reconstruction or rehabilitation, I think is not only unrealistic but arguably unethical. If you believe what I say and that the indications are very different, then putting them in a randomized group would be a disservice to about a third of the patients. It's very interesting that one of my patients recently was a lady that works at the VA, and I asked her what her job was, and she said, well, I randomize patients. And I looked at her for a minute, and I said, would you like to be randomized? And she said, no way, not me. So there are certain times where randomization is good, but when you have people that seem like one big homogeneous group like Sprague-Dawley white rats or something, I mean, you guys, I can recognize every one of you different from the other. There's just no similarity between people and certainly between your ankles so you can be randomized. You can see I'm a little hot about this issue. So the major procedures, ankle fusion, preferably in most physically active individuals under 60. They must have normal subtalar joint and ideally a well-aligned and supple foot. Ankle replacement is preferable in patients with subtalar and other foot arthritis, especially in patients over 65. The problem is that both arthrodesis and total ankle arthroplasty have a limited lifespan. Some fusions and some arthroplasties go a very long time, but about the average in each one is about 10 years. The conversion from fusion to total ankle is more logical, more often indicated and easier than converting from total ankle arthroplasty to arthrodesis, which for some reason is more common still. However, all this is true only if the conversion is planned. That means doing the fusion in a way that facilitates takedown and arthroplasty at a later date. The technique for arthrodesis when later total ankle is anticipated, of course, is an anterior approach. Remove all the cartilage, leave the subchondral bone. Major ligaments and malleoli are left intact. Obtain a perfect alignment, plantigrade position. Prepare the fusion surfaces by multiple drilling so it's not disturbed much in the terms of its strength of the bone. Or burring to make the shear strain relief sites, that's a longer subject. Well-placed 6.5 screws from positions that facilitate easy removal later. You don't want to spend the first half hour or hour of doing a total ankle trying to find the screws that were in before, so they need to be placed where you'll come right down on them. In summary then, total ankle is an acceptable alternative in treatment of end-stage ankle arthritis when done with the protocol-driven indications and appropriate associated procedures. It is still, however, somewhat unpredictable. So I would like to introduce the scientist of our group, Dr. Sangeorzan, who will not be just hot about things that he likes, but actually tries to integrate some science into what he's talking about.
The key is to pretend you're not hot about what you believe in. So what this is a brief data set slide from a prospective study we did comparing ankle replacement to ankle fusion in patients for whom there wasn't a clear indication for one or the other. And we're about 3.5 years into data collection. We've enrolled about 180 patients so far. We're running out of funding and trying to get it refunded for the next cycle. It is not randomized. It's prospective observational trial, and there are several reasons for that. One is patients don't want to be randomized, and when there's clear difference between the two treatment groups, you can't blind the outcome. And the psychometricians call this bias that the patients have on their outcome post-randomization remorse. So if patients want to have a fusion and they end up randomized to an arthroplasty, it's going to color the outcome measures that we use to randomize them. So in this study, we let them select the appropriate treatment and then study them before and after surgery. And so it's a prospective observational trial of patients already with end-stage ankle arthritis, already determined that they need to have an operation. They were enrolled consecutively after treatment. The study was done not by the surgeons, but by study coordinators who had no bias in enrollment or bias in outcome measures. When we surveyed our patients to ask them, how many of you would be willing to randomize? Only about 45% said that we would be willing to randomize. And mostly patients who would be willing to randomize were people who were told they couldn't have the treatment they wanted. So if some 32-year-old came in and wanted an ankle arthroplasty and I said, your age makes you inappropriate, that person said, well, geez, I got an arthrodesis. I'd rather have an arthroplasty, so I'd be willing to randomize. So we have a heavily biased patient population. So we included all the patients who could think and clearly answer the questions, who were independent ambulators, and who did not have systemic disease like rheumatoid arthritis that would affect their gait. They were enrolled by a study coordinator. The treating surgeons were all experienced in both techniques. There were 4 centers enrolling patients. We used objective and self-reported outcome measures so that the surgeons couldn't influence the outcome in any way. We studied them before surgery, 6 months, 12 months, and 24 months, and 36 months, although we're not there with our data yet. We used 4 different implant types for the arthroplasty group. This is an in-bone device. This is an Agility device, and we also used Agility's custom stems, and this is a Salto Talaris. The patients had whatever device the surgeon was comfortable with. We didn't influence that decision at all. We used the MFA, which is the Musculoskeletal Functional Assessment Tool. It's a 100-item self-reported health status measure specifically designed to use in healthy, active patients with musculoskeletal disorders. So this would be likely to be much more responsive than the SF-36 under these circumstances. Its content, validity, and reliability were established in a population of patients with injuries to the musculoskeletal system and with arthritis. It has no ceiling effect like the ankle osteoarthritis scale that's commonly used. To top out the AOS scale, all you have to be able to do is walk without crutches. We wanted to have a little bit more input than that. We wanted to know what type of activities they can participate in, because that group that both Dr. Veith and Dr. Hansen talked about, 65-year-old, isolated ankle arthritis, no subtalar disease, we really want to know what's better for that patient, because both work. We want to know what's going to be better in the long run. We compared pre-treatment MFA to post-treatment. So because this wasn't a randomized trial, we wanted to make sure we weren't having a biased group. So by using each patient as its internal control, you can get around the fact that we don't have necessarily matched populations. The statisticians use a linear mixed effects regression to estimate differences in the score in the study groups. We also used a stepwatch activity monitor. This is a little thing that you strap on your ankle and it counts your steps. It doesn't just count the total number of steps, but it counts the frequency, the duration, the number of minutes that you walked during the day, the number of consecutive minutes that you took steps, so we can look not just at their functional level, but how they got things done. The step count analysis we did by a custom code that we have used in the lab in other studies, and that you'll see in the analysis why that's important. We categorize the activity as low, medium, or high, peak activity, and duration of activity. These are the readouts you get. You can see they're very busy, but you can detail these step counts to find out really much more detailed activity. And we had a lot of people stop using these things because what does this look like? It looks just like the jail monitors, and some people turn these things back and say, hey, I'm not wearing this. Everyone's asking me if I'm on parole or not. This is the kind of readout you get, the walking bouts duration. This is the frequency on this side. This is the duration on the other. 20 consecutive steps was the most frequently occurring bout. So you think about what you do during the day. You don't get up and walk on a treadmill all day. You get up, you walk to the kitchen, make your coffee, you go to the car, you drive to work, you walk in the building. So little bouts of activity. All of you have been sitting here for 45 minutes, so you're going to register no step counts. It doesn't mean you're incapable of walking. So looking at these things in a detailed way helps us tell what people are doing. These are just different subjects, all showing that relatively conforming method of the number of steps they take each day. So we only have 41 out of the 180 patients who made it to a full year by the time this data analysis was performed. They were roughly half replacements and half fusions. We completed all of them with pre-op 3-month, 6-month, and 12-month assessments. And what we found is simple. Both of these operations work very well. They both relieve pain. They both increase functional activity. The MFA showed that the patients who had ankle fusions got better a little bit faster, but the patients who had ankle replacements had a higher functional level. There were recreational things they could do, and the number of steps they took was a little bit higher. So this is a very small study, but it slightly favors ankle arthroplasty over ankle arthrodesis in this non-controlled trial. And this is the summary, the dark line. Remember that the MFA scale, the lower the number, the better the outcome. And if you follow this line, that's an average of all the scores in the arthrodesis group and in the arthroplasty group, you can see that there's a trend towards slightly better functional activity levels in the arthroplasty group over the ankle arthrodesis group, but both had quite dramatic improvements from the preoperative position. So the MFA scores decreased strongly, correlating with increased function from pre-op to post-op in both groups, and that was statistically significant. The MFA improvement, change from pre-op to post-op, was a little bit stronger and barely statistically significant in the arthroplasty group. Step counts similarly showed very significant improvement, and this is a very busy slide, but if you look to the high activity and the maximal activity, these are where the greatest improvements occur. So if you have ankle arthritis, you still need to cook your breakfast, you still need to go to the grocery store. Your low-level activity is not going to change that much with treatment. But if you take away the pain of that ankle arthritis, you get a dramatic increase in the number of steps in a step instead of just walking to the grocery store and sitting down in a cart, you walk through the grocery store, you go out for a walk, and you go visit friends. So you use a lot more sustained activity and a lot more high activity counts. And that was in both groups, and there was not a difference between the ankle arthritis and the arthroplasty group. So steps at high activity improved in both groups. Peak activity improved in both groups. Treatment didn't affect the activity levels at low and medium activity, and there tended to be a slightly slower recovery time in the arthroplasty group when compared to the arthrodesis group. So surgical treatment works, and as Dr. Veith and Dr. Hansen just showed you, both of these options work. We still need a little bit better data to help us determine which patient should have an arthroplasty and which patient should have an arthrodesis, but they both work and they're both very functional. So I'm going to turn this back over to Andrew Merritt to field any questions. Thank you.
We can open up the floor. We have just a couple minutes left if anyone would like to ask our distinguished panel any questions. Could you please come to the microphone if you do have any questions?
I had a question for the panel. The first case that was presented had mirror image ankles, and I can hardly imagine a mirror image trauma story.
Yeah, he had room.
And I also have an orthopedic friend who is a spine surgeon, whose brother is also an orthopedic surgeon, and they have now had 4 ankle arthrodeses. And so I wonder to the panel how much of this really might be genetic and inherited rather than a trauma basis.
He did have rheumatoid arthritis, the patient that we presented. It was not post-traumatic, which is, as you mentioned, usually unilateral. But it's weird that only really his ankle joints were affected with any severity. As far as the genetic component, I think just the reading that I've done, there is obviously differences in people's cartilage that we see all the time when we look at knee arthritis, hip arthritis, and that's probably stands true in ankle arthritis. But as Dr. Hansen pointed out, there's very rarely a time when you can't talk to a patient about and find some ankle trauma in their history. So I think that has a significant role. What's your thoughts?
There is some reason to include genetic things because there's genetic trauma. Did you know that? Actually, what I'm getting at, though, is that a lot of the chronic injury in the ankle sprains are due to a bit of hindfoot varus or tibia vera, or things which are congenital. And of course, my big push is that we should be getting at some of these people early on. When you see an ankle sprain and they have preconditioned stuff like a gastroc equinus and a tibia vera or a calcaneal vera, those things should be corrected then, so that doesn't go on to repeat injuries, and then eventually we see them and have to fuse their ankle or do an arthroplasty. This is not popular in our community or in medicine in general, but I think we need to solve these minimal sort of genetic problems early enough that they don't go on to these problems, which eventually it is trauma because they sprain their ankle. But the thing that led them to being more predisposed to that is a genetic abnormality. So you're right and you're wrong. It is still mostly trauma.
Also, we looked at 800 of our patients to see what the etiology of the ankle arthritis was. And very similar to the report from the Iowa group, that out of those 800, about 75% were clearly post-traumatic. They had an ankle fracture, tibia fracture. Then when you took out the post-septic, the rheumatoids, the Reiter's syndrome, the hemophiliacs, we were left with about 6% in our group, only a percentage different. When we looked at the x-rays of those 6%, 75% of that 6% had misalignment in the coronal plane, either a cavus foot, a valgus foot, a cavus or valgus knee, or a varus knee. So we were left with about 1% that we couldn't really attribute to misalignment or trauma or recurrent sprains. So there's probably a small number out there.
I greatly enjoyed the conversation this morning, and I just want to ask a question in 2 voices. The first, that of the resident, and the second, that of the guidelines and oversight group at the AAOS where I participate. From the point of the resident, they finish a meeting like this and they say, when I go out, how am I going to decide what to do? And it can't be who won the debate, and it can't be who was the most articulate or appealing at the podium. It is that we teach them here to go to the literature and to look at the quality of the literature and the evidence that's there to make their decisions. And that, sadly, is really lacking in this area. The American Academy of Orthopedic Surgeons just tried to do a guideline, evidence-based guideline, and was unable to do it. The literature was of such low quality. And so they did a technology overview in which many of the questions which were brought up and answered today are still not there. Things like which works better. And the literature says that the groups who have ankle fusions are different than the groups that have ankle arthroplasty. So they can't come to a conclusion. But what are the predictors from each of those groups that give the good result? That still is not available in the literature. So I think that there's an imperative for the knowledge of Dr. Hansen about who kind of knows what works and what doesn't work. And this level 2 study that you're doing to find its way out there on behalf of the residents who are there. The technology oversight is in its final stages and will probably be published on the AAOS website in short order and be disappointing to the many of us who really value a heritage of strong orthopedic literature to help the residents. So
Thank you.
keep it up.
Dr. Sangeorzan could probably talk about the struggle that he's had with this grant. And
Yeah, I would completely endorse everything you just said. And in fact, the technology, when the Academy can't find enough evidence to come up with a position statement, they create this technology assessment. And the technology assessment was sent to us, the members of the AOFAS board, and we asked them not to publish it because it's just as flawed as the primary data. So I think I would completely endorse it, and I'll send you a stack of all my grant funding rejection letters trying to get this study funded, and having the people who sit on the panels say, everyone knows that both of these operations work, so there's no reason to study it. So that takes us back to the minutes before we started this meeting saying orthopedic surgeons need to be doing research, and orthopedic surgeons need to support the Orthopedic Research and Education Foundation.
I'd like to say thank you to our speakers and thank you all for joining us today.